So many of you will have heard of a tremendous enthusiasm for a new drug called eculizumab, and my colleague Neil Sheerin has been responsible for undertaking trials for eculizumab here in Newcastle, so he's going to be talk to us about eculizumab and treatment of aHUS.
All right, thank you very much, Tim, and it's great to see so many people here interested in working in this disease. I think that Mark's earlier talk gave a very good example of what we all aspire to in medical research, of closing this translational circle, of taking patients with a very severe disease, understanding the mechanisms of disease, and then developing and designing therapies that allow us to treat that disease. And I think with atypical hemolytic uremic syndrome, we're very close to actually closing that loop. And eculizumab, as with liver transplantation, is one of the ways that we can do that. So the scene has been set very well today, and people have given exceptionally good talks prior to mine of explaining what aHUS is and how atypical aHUS and complement are related. And atypical hemolytic uremic syndrome is caused by uncontrolled complement activation. And what that does is it causes the formation of clots in blood vessels in the kidney, as Sally described to you earlier on. And we see consumption of the red cells and the platelets within those clots, which causes the anemia and also causes the platelet count to be very low. And they're very characteristic of atypical hemolytic uremic syndrome. And the consequence of these clots forming is that there's kidney damage and eventually kidney failure. And it's a combination of these factors which make people feel ill. And people with aHUS do feel ill, as you've heard earlier on. And also, as well, even though we have treatments with plasma exchange and plasma therapy, it has to be remembered that they're supportive treatments, and there is a burden of the treatment. It's not straightforward, and we've heard about difficulties with access to allow the plasma exchange to be performed. Now, this is the complement pathway, and there'll be a test on this after the meeting. But essentially, as Matthew explained, there's 3 activation pathways. And it pivotally goes through this factor C5, which produces several very active proteins which cause the killing, the firepower, as Matthew described, of the complement system. Now, that is normally designed, as Matthew explained, to kill pathogens and protect the body from infection. But if it misfires, as it does in atypical hemolytic uremic syndrome, with inappropriate or inadequate control, what we see is injury to self. The complement system damages our own cells. And as Sally explained earlier, we see damage to the blood vessel walls and thrombus and clot formation. So if we can block C5, we can also block the damage that complement does. And having been going to meetings about complement and complement research for many, many years and seeing the increasing understanding of how complement caused disease, one of the very frustrating things as a clinician was that we never had any way of doing this. We understood this intimately, and we understood how this caused disease. But what we couldn't do is block it in a therapeutic, safe manner. And for many years, this has been one of the sort of holy grails of complement research. And I think now we're at a point when we do have one, at least, effective therapeutic agent which does this. And in likelihood, in years to come, there will be more and more agents becoming available to us to do this. And the agent we have at the moment is eculizumab. Now, again, going back to this jargon, we do love our jargon. Eculizumab is a humanized monoclonal antibody against C5. It's produced by Alexion Pharmaceuticals, and it very effectively blocks activation at the C5 point. And therefore, as Matthew explained, that blocks a lot of the downstream effects. It has been successfully used for the treatment of this other disease, again, with Matthew mentioned, paroxysmal nocturnal hemoglobinuria. And this, again, is a life-threatening disease which is characterized by excessive inappropriate complement activation, which destroys our red cells. And I think there's a lot of similarities, not only in the biological mechanisms of aHUS and paroxysmal nocturnal hemoglobinuria, in that they both involve complement, but I think it's also important to remember that they're both rare diseases, and they probably have a similar number of people affected with aHUS and PNH. And also, they're both treatable with eculizumab. They've also gone through the same types of commissioning issues that Mark referred to earlier on, in that there is now a sort of a centralized commissioning process for the treatment of PNH with eculizumab, which could be used and can be a blueprint for the way aHUS could be managed, which you'll hear about later on. So monoclonal antibodies, I mean, that's something that some of you will have heard of, but many perhaps won't. And what are they? You've heard a bit about antibodies from Matthew's talk, and antibodies are proteins that the body produces normally in order to combat infections. So they're a biological treatment. They're using a protein to treat disease. The first monoclonal antibody was licensed to treat disease about 25 years ago in 1986. And that was a treatment which targeted the immune system. It's an antibody called OKT3. And it's an antibody that people who work in transplantation, and I work in kidney transplantation, will have used to treat bad rejections. And it was a very powerful antibody. Since then, this field has moved along a massive amount. And probably, of all of the new treatments that are coming along for any diseases, there are probably more treatments with monoclonal antibodies being developed and being tested than in any other field of medicine. This is an area of great, great progress and advancement. We now have monoclonal antibodies used to treat cancer, to treat cardiovascular diseases, to treat rheumatological diseases. Some of you may have heard and read in papers about these anti-TNF treatments, which have really revolutionized the treatment of rheumatoid arthritis. Inflammatory diseases in lots and lots of different areas can now be treated with monoclonal antibodies. Osteoporosis, a common disease, there's now a monoclonal antibody to treat that. And we use it still very, very commonly in transplantation. All of our patients going through a kidney transplant in Newcastle will get a monoclonal antibody of some sort. And the word monoclonal means one type. So we've got one type of these antibodies of proteins directed against something. So this is what a monoclonal antibody does. If our immune system sees something that shouldn't be there, it mounts an immune response to try and get rid of it. And one of the components of this immune response is mediated by these cells here, which are B cells. So the B cells sees these foreign proteins or pathogens, or indeed a transplanted kidney or liver, and it will start to produce antibodies. And each cell will produce one antibody. And these antibodies will all be different. What happens, these antibodies bind to the target, and they produce a lot of effects. If it's a bacteria, for example, the antibodies can lead, with complement, to the killing of those bacteria. If these antibodies are directed against a single protein, what they can very effectively do is to block the function of that protein and stop it from working. So it doesn't have to lead to killing, it can be an inhibitory antibody. What we can do in the laboratory is to take these cells of the immune system and isolate a single cell. And that single cell will only produce one of these types of antibody. So we get a system by which we get one cell producing multiple copies of this antibody. And it's all directed against the same target. And by various processes in the laboratory, what we can do is we can get these B cells to divide up into quantities on almost an industrial scale to produce billions and billions of copies of this one single antibody, all of which are identical and all of which are directed against the same target. And we can do clever things to make these antibodies very easy to administer and also very well tolerated by the patient that we're giving them to. And this is why these are so powerful, because essentially this can be anything. You can decide upon which target you want to aim your immune response against and produce these monoclonal antibodies. So if you've got any particular target, it's not easy, but it's possible to create a monoclonal antibody which targets it. And what eculizumab does is target C5. And it blocks the function of C5. And very effectively stops it from working. And thereby stopping activation of those downstream pro-inflammatory, disease-causing effects of complement. And these can be produced in the antibodies and are very commonly now used to treat disease. So can eculizumab be used to treat atypical hemolytic uremic syndrome? Well, theoretically, yes, it can. Certainly should be able to, because we know how it works and we now have an agent to block it. As with a lot of these things, the first evidence comes from anecdotal, single patient experience. So we had a patient with this and we treated them with X and it seems to work. And that's a good starting point. But it's not really enough to convince the medical establishment and the commissioners that this is the right treatment. And what we need to do is to do clinical trials. And clinical trials are difficult, and in rare diseases, they're exceptionally difficult. But we're now at a point that we have clinical trial evidence that eculizumab works. And there have been 2 studies which have been reported recently at meetings, and we've participated here in Newcastle, and there's been participation at other UK centres. The first study was one of people who had a new episode, a flare of their aHUS. And these patients were resistant to standard treatment, so people who were not responding to plasma exchange or plasma infusion. And because they weren't responding, it was an early intervention. We had to use the eculizumab quickly in order to try and control the disease. Now, we recruited across the study 17 patients. Now, that doesn't seem many, but this study required, I think it was 73 centers, kidney centers across the world were approached. 60 centers started to try and recruit patients over about an 18-month period in 11 different countries across Europe and across North America in order to get 17 patients. That just shows how difficult it is to complete these sort of studies. This was a study that was in adolescents and adults, so it didn't include children, although there is a trial in children undergoing testing at the moment. So the age range was from about 17 to 68 years of age. 6 patients who were included in this had been on dialysis before they were included in the study, and 5 patients were actively receiving dialysis when they were recruited. Now, that's not people who've been on dialysis for years and years. This probably won't work in that situation. These are people who've got a sudden flare of the disease and require dialysis as life-saving treatment. I think an important thing to say is that of these 17 patients, 40% had the disease in a transplanted kidney. So people who probably had aHUS causing their kidney failure in the first place, perhaps it wasn't recognized at that stage, and have then gone on and developed it again in a transplanted kidney. Of those 17 patients, 15 completed the study without major problems. Of the 2 people who didn't complete the study, 1 was withdrawn from the study because it was worked out later that this was the wrong diagnosis and they didn't have aHUS. The second person had to be withdrawn from the study because of an effect that probably wasn't related to the eculizumab, but related to a drug they were taking concurrently at the same time. This is how the patients were dosed. It was a 26-week study. And clearly, for a disease that lasts a lifetime, you have to accept this is only the first 26 weeks. When patients were included in the study, they had a weekly dose intravenously of the eculizumab, And then after that first 4 weeks, the patients received a fortnightly dose of the drug up to the 26-week period. This dosing schedule really is very effective at completely abolishing complement activation. The patients who completed this 26-week period, and you'll hear from someone who's been through this, were then allowed to carry on. Because clearly it would be no good getting to this stage for people and stopping the drug, only for the aHUS to come back again. So everybody who participated in this phase of the study then went on to continue out. And it must be getting on to 2 years now of treatment data available. Again, as Matthew mentioned, we do get concerned about this infection, this meningitis caused by meningococcal bacteria. Everybody who entered this start of the study had to have vaccination against meningococcus, which is very good at actually preventing this very serious form of meningitis. And I do think we have to remember that we are inhibiting part of the immune system which is there to protect us from infection, so it may not be completely without problems. So did it work? Well, as I said, platelets are these cells that cause the blood to clot. And one of the typical features of atypical hemolytic uremic syndrome is that the platelet level is low because these are being consumed inside the clot. And what we found was that upon starting the eculizumab treatment, platelets rapidly went up. And they improved within 7 days after the first dose of eculizumab treatment. 15 of the 17 patients completely normalized their platelet count. And on average, the platelet count went up by about 100. And that won't mean much to you, but that's a big jump in platelets. So that's a very significant response. And this was it's 13 out of 15 patients achieved the normal counts, 87%. So that's a very positive result. And remember, these were patients who had low platelet counts who were not responding to plasma exchange or plasma infusion. This disease would have continued on unrelentingly, probably towards kidney failure, without this change. This just demonstrates the effect. This is the platelets going up on the top here with treatment. And many of you will know that the way we measure kidney function is by looking at the creatinine level within the blood. Creatinine is a waste product that's removed from the body through the kidneys, and as the kidneys work less well, the creatinine level goes up and up and up. When we start treatment with eculizumab, the creatinine level comes down and plateaus very nicely. I think perhaps the most impressive result of this study was that of the 5 patients who were on dialysis prior to starting this study, 4 of those patients came off dialysis completely. And again, pointing out, these are patients who hadn't responded to our best standard treatment that we had available. I think platelet counts are very, very important to physicians, but in fact to patients is, how do you feel? What's the quality of life that you have? Is a treatment improving that? So as part of the study, we collected data on quality of life and basically asked patients, how do you feel? There's a questionnaire to do this, and from big studies that have looked at this questionnaire before, if you get a score that increases by 0.06, that would suggest that your quality of life has got better. And this is the results from the people who participated in this study. The quality of life went up by a very, very significant amount in the majority of patients. So it improves the parameters that we as doctors look at, platelet counts, but it also improves some of the parameters that's most important to the patients, as that's how they feel. And it comes back to some of the points that was made by Mark. This is not just about understanding the numbers and the counts that doctors are involved in. This is a much bigger picture of understanding how treatments influence disease. Second study was running at the same time because there's a group of patients who, and there may be some of you in the audience, who have been on plasma exchange regularly, who where the plasma exchange is controlling the disease, keeping it at bay, but there's a long-term requirement for twice weekly or weekly plasma exchange. And the second study looked exactly at that. So these are people who were responsive to plasma therapy and on maintenance treatment. And in these patients, it was working. It was controlling the disease. But it's not without problems. As we heard before, plasma exchange can run into problems with access and other issues. So this was the sort of later intervention of people on maintenance. There were 20 patients, about similar sort of age range, from 13 to 63 years of age. And basically, eculizumab worked in this situation as well. And the people were not in kidney failure, they weren't on dialysis, but had impaired renal function, and that just carried on. It's perfectly possible to substitute eculizumab treatment using exactly the same dosing schedule as I described before for plasma exchange. It's as good, perhaps even a bit better than plasma therapy in terms of controlling disease. And it was fairly well tolerated. We didn't see any cases in either of the study of meningococcal meningitis. There were side effects: anemia, headache, diarrhea, vomiting, nausea. But I think we have to remember that this is a group of people who've got quite a serious illness, will have symptoms. And how much of this was related to the disease or related to the drug is difficult to tell. Every problem would be recorded. And we can't tell if someone's feeling a bit nauseated one day, whether it's the drug or whether it's the disease or whether it's something else. But it would still all be recorded. And only 2 of these, it was 1 case of anemia and 1 case of headache, were reported as severe. As I said before, 1 patient withdrew because of a side effect which probably wasn't related to the eculizumab itself. So no one out of the 36 patients probably who were dosed to completion in this study had to withdraw because they couldn't tolerate it, and probably couldn't tolerate it for another reason. So just some concluding remarks about eculizumab. I think it is a safe and effective treatment. It is another option now to continuing plasma exchange or to liver transplant. It certainly seems to improve kidney function in people with a recent onset of aHUS. It can be substituted for plasma exchange. It doesn't require central lines. It can be given through a simple drip into the arm. It requires, for maintenance treatment, to be given once a fortnight, whereas plasma exchange may be several times a week or weekly. This is a key thing as well. It does allow people to be transplanted, and the point was made earlier about the current view is if you have a mutation in most of the complement genes, you're not a candidate for transplant. Because I think that Sally showed that 80 to 90% of people with, say, for a factor H mutation, if they receive a kidney transplant, will get the disease back in their transplant. Eculizumab offers a way of starting perhaps at the time of transplant and giving eculizumab to prevent the recurrence in the transplant. This wasn't included in part of the study, but it certainly represents, I think, a very exciting and potential therapy that we can offer now to people who are deemed untransplantable, perhaps at the moment, with the exception of perhaps a liver-kidney transplant combined. This is a realistic alternative now. And I think at the sort of a recent sort of straw poll on this, there may be 70 patients or more in the UK at the moment who are on long-term dialysis, not on the transplant waiting list because it's deemed that they're not suitable for a transplant. The fascinating thing, and perhaps one that was unexpected, is that to go into these studies, you didn't have to have a defined mutation in one of the complement proteins. So you didn't have to have an abnormality of factor H, factor I, CD46. The reason for that, largely, is because often people needed to go into the trial at that point, and it takes maybe several weeks to do the genetic testing. So everyone was allowed to go in. And the results of the people in the study were the same, irrespective of whether we then subsequently found a complement gene mutation. So I think of the 35 or so patients, about 10 or 12 of those didn't subsequently turn out to have a complement mutation, and they did equally as well with eculizumab. That's all I'm going to say, but I'm going to introduce two people to you now who'll give an idea of eculizumab therapy from two rather different angles. And ask Caroline to come up, who actually participated in Glasgow in one of the studies that was taking part. So it was one of those numbers that you saw up there on the screen, and can give a personal experience, giving a better sort of global understanding of what this trial has done.
I took ill 3 years ago. Previous to that, I was very, very healthy, had no major health problems whatsoever, and took very ill very, very quickly, very suddenly. Spent a few days in a high dependency unit where they diagnosed me with TTP or aHUS, they didn't know, and proceeded with a treatment of plasma exchange. I later then developed severe kidney failure and was transferred to a hospital where I could go straight on to dialysis. I spent 3 weeks having daily dialysis and daily plasma exchange, and it really wasn't doing very much. After maybe about 4 weeks of plasma exchange, eventually my platelets started to come back up and things started to look as if they were maybe getting a bit better. And then my heart decided to join in on the act. I was then transferred to a cardiology unit and spent 2 weeks there while they tried to work out what was the best treatment for my heart, because that was beginning to fail, and just joining in with the fun. So they put me on lots of heart medication, and eventually I got let out of hospital and they said that should be me. Great. So I went home, still having kidney failure, but not as severe, didn't need dialysis, and was on heart medication, but they said it should all be okay. And then within a month, I relapsed, and I was straight back to hospital, and back to dialysis, and back to plasma exchange, and then it was daily plasma exchange again for 2 weeks. And then I went home, and that should have been it. And then about 3 weeks later, it all happened again. And that pattern continued for about a year and a half. And I very luckily had a fantastic consultant who was very heavily involved in researching for me and trying to find the best possible things for me, and was very supportive, even although generally when he walked into the hospital room, I very quickly fell asleep. So he then found out about eculizumab, and I have been now receiving it for a year and a half. I have not relapsed once in that time. I haven't had any plasma exchange. I now go once a fortnight, have a drip put into my arm for 35 minutes. I stay in the unit for an hour after that, just so as they can make sure I'm okay. I've never had any problems with it. My kidney failure is now not normal, but it's stable. My heart condition is completely normal. I've been signed off by cardiology, and prior to the eculizumab, I was receiving counselling to get me ready to go into permanent dialysis. They're not even talking about that anymore. I see a renal consultant once every 3 months, basically to say hi. And that's me.
I also mentioned that eculizumab can open up the possibility of transplantation for people who aren't caught early enough or have developed end-stage kidney failure. And we also have, as mentioned at the beginning, people from Spain over here. And Francesco, if you're just come and tell us your experience, not of your personal experience, but the experience of your young son.
Hello. First of all, I apologize for my English. We are from Spain, so I don't know if I can transmit what we've been suffering with our youngest son. 4 years ago, he suffered this disease, and by this time we didn't know what it was. Doctors perhaps couldn't transmit to us exactly what it was as well, or it could happen in the near future. So Jose been in dialysis for 4 years. Along this time, we tried to understand, and we went to many places to talk with doctors. And we got the chance and the opportunity to meet Dr. Giuseppe Remuzzi in Bergamo. And 3 years ago, he already mentioned this eculizumab like one of the good opportunities for the near future. We should wait until the authorities allowed, and obviously other studies would come with good results. So last year, doctors in Spain offered to us different options, like the double transplant, the liver and kidney. But, well, thanks to be in contact with the most experienced people, they said, or they say that this drug would be by this time and the situation of our son, probably the best option. So last September, he received the kidney transplant, and at the same time, eculizumab was given to him. And so far, for 9 months, everything is good. The life changed completely because he was on dialysis every 2 days. And now we have to come to the hospital for eculizumab only once every 2 weeks. So we try, and probably this is one of the most important things, that this illness obviously could be in any of us, but the life has to come on, and the most important is to look at the future and to enjoy the life. Thank you.
Thank you, all three of you. That was just fantastic. Anybody got any questions for our three speakers here?
Hi. Our daughter developed atypical aHUS last year, but she was in acute renal, well, it was probably chronically developed, but her creatinine, for instance, was 2,500 on admission, and hemoglobin about 3.6. And she was already quite, what's the word? Very swollen, and she went into respiratory failure. She rested. She had the can't pronounce it.
The eculizumab, yeah.
Yes, she had that after 3 weeks in intensive care, but unfortunately she arrested the day she was given it. It's an impossible question to ask, but perhaps if she had been given this earlier on, or would her renal failure have been so severe that it might not have been as effective?
I think it's obviously a very difficult situation, but I think the earlier that this disease is recognized and the earlier that the right treatment is initiated, the more likely there is to be a successful outcome. And I think that one of the roles of us as doctors and groups like this with patients' involvement is to ensure that the information is out there about atypical hemolytic uremic syndrome, because I think we know it's a very rare disease. Many doctors will never see a case of it. And so it's not at the forefront of their mind to be thinking about this. And we've heard a beautiful example of how patients with family members can ensure that the profile of this disease is kept at an appropriately high level. And so recognition and prompt treatment will give the greatest likelihood of a good outcome. Whether it would have affected the situation, as your child was obviously very, very ill at the time, is difficult to say with certainty. But overall, the earlier, the better is the message to get across. And that does mean recognition and, people being aware of families with other family members and ensuring that the doctors looking after other family members are aware of this problem, make the diagnosis quickly, allowing them to initiate treatment. And they don't all have to be experts. There are experts around who could be at the end of a phone. We're not expecting every doctor to become an expert in aHUS. We are hoping, though, that people will be able to pick up a phone and find out someone who is.
Do you mind if I just mention the trials in children? The data that Neil's presented is from adult studies and adolescents. The youngest patient was 13. I think it was one 13-year-old, one 17-year-old. There are trials currently going on now in children down to the age, John, help me, down to the age of 1 month or 5 kilos. That's a big 1 month old, but so 5 kilos essentially, and that's an international trial that's going on. But we know of a lot of anecdotal data from case reports in children, just as they came out in adults before the trials, where eculizumab has been used in patients such as your son. So children who've received eculizumab not in a trial setting, and those have been reported, and very similar results that we're seeing, a quick response in platelet count and children coming off dialysis. So the medical community like trials because that means the evidence is there and clear, and it makes it much easier to prescribe medicines when we know they've been studied in those settings. But so those are underway in children, and we're trying to get the ball rolling with getting this drug more available, so that when those trials are definitely reported, that we can sort of instantly use it.
I think another point about the trials is a lot of clinical trials will say, well, we'll test one thing against another. That isn't the way that these trials have been designed. So if people are entering these studies, we're testing whether eculizumab works, and we're giving everybody eculizumab. So it's not a trial of eculizumab versus nothing. So it is important that you wouldn't be denying yourself a treatment by entering into these types of studies.
We read a little bit about the eculizumab, and again, I'm not sure whether we fully understand, but what I initially read seemed to indicate it was more beneficial for factor H and factor I. Now, Arson's CD46, is it applicable to all three, or?
I think that there'll be relatively small numbers of patients with individual mutations in this study, but what's clear is that if you've got the disease, it doesn't really matter what the underlying mutation is, or indeed even if there is a mutation.
Right.
The treatment of eculizumab seems to work with all comers, irrespective of the actual trigger that's led to the disease. So there's no reason to think, and indeed every reason to think, that eculizumab would be effective in people with a CD46 mutation.
Any more questions? If not, I'd like to just thank again our 3 speakers here.